start from anatomy to pathology. So pediatric temporal bone diseases vary from adult in terms of pathology and imaging characteristic. The clinical signs and symptoms of most of the disease entities are non-specific, including pain, discharge, or hearing loss. Radiological imaging plays an important role in narrowing the differential diagnosis and guiding the clinical management. The first talk of today will be a review of the basic temporal bone anatomy, talk briefly about the embryology and the radiological findings for pediatric ear pathology. This will be the content for today. So starting with the anatomy, and when we do the temporal bone, we have the axial and the coronal high resolution cuts. So starting with some cuts through the axial, we'll review quickly the anatomy. And usually you should have an approach. So you would either start from the external and going to the inner ear structure, or you start from the inner ear structure going all the way to the external. This way, so you don't miss any of the structures that you need to check when you read a temporal bone CT. The way I would use and the way I taught, it was starting from the external. So we'll start from the auricle, the pinna. Usually went on the pinna just because these can get deformed by the way that they place the headset when they scan for the CT. It can look deformed, but it might be just normal. And it's also something that's clear for the ENT doc that they can see it. So it's not really important to comment on it. And I mean, you would say it's deformed, but then it's normal and we will be in a bad shape. And then we go to the external auditory canal. We have the cartilaginous portion, then the inner portion, which is the bony portion, and then goes to the tympanic membrane. Again, I don't say in my template that tympanic membrane is intact, just because, again, like the resolution of the CT, that we don't see really clearly the tympanic membrane, and if there's any perforation, we won't be able to see it. I would say the tympanic membrane is thickened, is retracted, like the way I would see it. And also, if there's any perforation, then the ENT doc can see it. And as we go from the external, then we get to the middle ear cavity. So on the next cut, I would say when you are in, if that's really like the alignment of the CT or the axial cut of the CT is a proper alignment, then the external auditory canal, you should look and see at that level the basal turn of the cochlea and then the cochlear promontory. That's one of the kind of landmarks to make sure, okay, you are in a proper alignment for the axial cut. And then the next cut, you should see the two lines for the ossicles, so which is the malleus, and then the longer process of the incus to the encodostapezial joint. So two lines, and then we will talk about the ice cream cone. But for now, you need the two lines for the ossicles. And now we start seeing the round window, which is at the end of the basal turn of the cochlea. I don't want to talk about the others here. And then again, next cut, still you have the two, the malleus and the incus. You start seeing the stapes in a better shape. And then from the cochlea, now you're start to seeing the rest of them. Middle and the apical turn of the cochlea. There's an important structure within the cochlea that you need to make sure it's there, called the modulus, which is just a piece of bone near the cochlear aperture, and then all the interscalar septation is connected to that modulus. Sometimes when there's deformity of the cochlear development, then you don't see the modulus there. And that for checking for the cochlear aperture, it should be more than 1.8 millimeter. Just to keep in mind, like around the 2 millimeter range, I don't use much of the numbers for measurements of the temporal bone. It's more as like being the internal evaluation with the other structures as we will go through the lecture. There's an important structures sitting there more posteriorly within the middle ear, which is the pyramid in the middle, and then more lateral, the facial recess. and medially the sinus tympani. And it's important for us in terms of radiology to check and make sure that this area is clear, just because sometimes the cholesteatoma can sit there within the sinus tympani, and it's more as a blind spot for the ENT doc, that they don't see it when they go and check for the middle ear. Next, we get to the ice cream cone, which is composed of the malleus and then the short process of the incus. And as we see here, so then we have more of them mastoid air cells, and then there is this connection or tract canal that connect basically from the mastoid air cells to the middle ear cavity. It calls the adytas ad antrum. And then the septum there called the corner septum is not that much of importance, but that the adytas ad antrum, the importance of it just tells you that there is a connection between the middle ear and the mastoid air cells, and that's why most likely when we see mastoid effusion, we would see also middle ear effusion. Moving forward to the rest of the structures, now we start seeing the vestibule, the lateral semicircular canal, posterior semicircular canal, and then vestibular aqueduct. So for the vestibule, again, I know there are so many measurements, but the way I would use it and the way I taught is that you can evaluate the vestibule compared to the bone island that's sitting there where the lateral semicircular canal is, and it should be that the vestibule is smaller than the bony island. Sometime when we would see when there is like semicircular canal and vestibular hypoplasia, you will see that this structure become more globular and bigger, and then you will see that it's become bigger than the bone island. So the bone island becomes smaller, and then these structures are bigger. And then you have the inner ostomy canal, and again, for internal reference, it should like up to 1 millimeter difference between the two sides is acceptable. More than this or more than the 1 millimeter, then you would think that it could be there's an abnormality in one of the internal auditory canals. And we know that there is the cochlear nerves goes to the cochlea, and then we have the facial nerve with the labyrinthine segment to the geniculate segment, and then we have the tympanic segment. Again, this is the adytas and antrum that we talked about. Important to check here that there is the sigmoid sinus, and then the sigmoid plate is intact, and there is no communication with the mastoid air cells. As we continue, we get to the superior semicircular canal, and then the other view for the posterior semicircular canal. You can see that here is the epitympanum, which is basically the one that's more connected to the mastoid antrum or the adytas ad antrum. So that concludes the axial cuts. Now talk about the coronal cuts that we will see. So on the coronal cut, the first thing that keep in mind, if you have like a horizontal lines that goes through the upper border of external auditory canal all the way through the middle ear cavity, then the one on the top, that's the epitympanum, and then the one in between the two, that's the mesotympanum, and then the bottom one, that's the hypotympanum. So the middle ear cavity is separated into 3 spaces: the epitympanum, mesotympanum, and then the hypotympanum, which is the lower portion. Okay, and then from the external to the middle ear cavity, you have this small piece of bone that it's part of the checkpoint for us, that it needs to be clear and pointy. That's the scutum. The space in between the scutum and the malleus, that's what's called the Prusak space, which is an important, as we will see later, because cholesteatoma can happen there. So this is part of the important structure within the epitympanum. We have another structure which is kind of within the mesotympanum. It's the tensor tympani muscle and then tendon. It's important to pay attention that this comes in a different cut than when we will see the stabies. So don't mistake this for stabies. Stabies sits on the oval window, as we will see soon. So again, part when you're checking for the epitympanum, there is the surface that's covered, or the bone that's covering the middle ear cavity, called the tegmen tympani. We have tegmen mastoidum that's covered the mastoid ear cells. It's not really that important, just because the tegmen tympani, that's where most of the cholesteatoma happen. And then you need to check that there is no erosion in this location. And if there is any erosion, then there is no temporal lobe herniation, or like encephalocele or just a meningocele that's herniating to the middle ear cavity. If you are doubting it on the CT, then MRI is definitely recommended with DWI images, the diffusion weighted, to make sure that which one is cholesteatoma versus being the brain tissue. And it's an important thing to highlight it to the ENT doc, so they don't go there clearing cholesteatoma with the temporal lobe. And then, so we start seeing the malleus here. There is an important point. So this where the oval window, which we will see it on the next cut, but then on the edge of the oval window, we have the tympanic segment of the facial nerve, which is an important landmark that we need to check. And then the area between the where the stabies sit on the oval window and the tympanic segment of the facial nerve is the fistula antifenestrum, which is an important location to check every time. It's more as an adult thing, more than being really for pediatric, for fenestral autosclerosis. So next, that's when we get more from the incus and then the stabies sitting on the oval window. We have the lateral semicircular canal, and then the superior semicircular canal covered by the arcuate eminence. Again, more of the stabies. What I want to say here, so that's the cochlear promontory, which is the same cochlear promontory where basically where the basal turn of the cochlea sit, and then the protrusion that covering around that area is the cochlear promontory, and then soon to be we have so basically the basal turn of the cochlea connect with the vestibule, and then the opening between the two, that's where the round window, or what they call it, round window niche. So as I continue, that's where the jugular foramen and part of the tympanic segment of the facial nerve as it continue to become the mastoid segment through the sternum, the mastoid, stylomastoid foramen. Okay, and just to talk like briefly about the articulation for the ossicles. So we have the malleus that's sitting on the tympanic membrane, and then the incus here. So from the malleus, there is the manubrium of the malleus, and then from the head of the malleus that articulate with the incus. Incus has the short process, and then long process with the lenticular process, and then the stapes is sitting on the oval window. So that basically concludes the anatomy. Any question before I proceed?
Any question, please? Okay.
Okay, so we'll talk briefly about the embryology. And I'm not going to talk too much really about the embryology. I know we hate it. I know we don't like it during the medical school, but also it's ear embryology, so it's not going to be something easy. I will just highlight some of the points that it's kind of important for us to know and to think about it when we think about congenital ear abnormality. So around the 4 weeks of gestation, that's when the ear structures start to develop, and it's basically related to the bronchial apparatus, which on each side of that bronchial apparatus, there are 6 arches that forms the mesoderm. There are 4 clefts. So as you can see here, these are the clefts that forms the ectoderm, and then pouches on the inner surface that forms the endoderm. Okay, and then we'll see what's the importance of all this on the next slide. And then there is another area that called the otic placode. as you can see here. So that otic placodes, it's basically part of the surface ectoderm or what's called neuroectoderm, and that's responsible about the development of inner ear structure. So that's a separate things from the neuroectoderm, resulting in inner ear structure development. That's again another cut. So the external portions are the cleft, and then the inner portions are the pouches. From that, we see that the external, so the first bronchial cleft forms the pinna and the external auditory canal. And then on the first bronchial pouch from the internal, so that's the internal portion, give us the tympanic cavity. And then the first and second bronchial arches, all the arches, give us the three ossicles. So with that we see is the external auditory canal arising from the first bronchial cleft, basically the external one, and then the middle ear cavity itself from the pouch, which is the inner structure, and then the ossicles from the first and second arches. And that's totally different from inner ear structures, which is arising from that the otic placode that we talked about, that gives the neuroectoderm, subsequently gives the otocyst bud, which will give us all the membranous labyrinth, including utricle, saccule, semicircular canals, endolymphatic sac, duct, even the cochlear duct. So then what do we have? If we have all the membranous labyrinth, there is only the bony labyrinth remaining, which is from the mesenchyme surrounding the membranous labyrinth. I hope this is like really brief and to the point. So then to summarize all this, the take-home point from this is that inner ear abnormalities are totally separated from external or middle ear abnormality. So when we get an order for microtia or external auditory canal atresia, then you should think in the back of your head that most likely inner ears are spared. Like you don't have much of abnormality within the inner ear structure, but you are mostly expecting that the abnormality will be external and middle ear abnormality. Just because each one, like the embryology for each of these are totally separate. And then when we have external or middle ear anomalies, that's what give us the conductive hearing loss. However, the sensory neural hearing loss is mostly related to inner ear abnormality or the cochlear, vestibulocochlear nerve. Okay, so that concludes the embryology. Any question about the embryology before we go to cases?
Any question, please? Okay.
Okay, so we have 5 cases. So you guys can decide who want to take the first case.
Dr. Ahmed Mahoud.
You can describe what you are seeing. I can help you with saying that this is axial cut and this is the coronal cut.
دكتورة رواء. دكتورة إسماء خزعل.
نعم أستاذ، صباح الخير أستاذ.
صباح الخير. Your comment.
نعم ممنون. Coronal and axial of the temporal bone showing soft tissue mass in the bronchus space اللي هو between السكوتم and the ossicle extended to الميزوتيباني ومسوي erosion مالت السكوتم.
Okay, so what do you think the diagnosis?
كوليستياتابا.
Okay. Well, I mean, we'll see through the talk. Next case. Thank you.
دكتورة أسيل.
نعم أستاذ. صباح
تفضل.
الخير. incidental finding, MRI, multi-sequence. I see there is hypertense lesion on the right side of the temporal at the apex of the petrous bone. T2 hyper, and T1 without contrast, also hyper. T1 with contrast, without enhancement. I think it is cause expansion, cholesterol granuloma.
Okay.
يعني my diagnosis. Thank you.
Okay. Thank you.
دكتورة إيناس فالح.
نعم
دكتورة
أستاذ.
مرة.
نعم أستاذ.
تفضلي إيناس. Your comment.
أجزاء نعم أستاذ. axial section CT scan of the temporal bone show complete opacification of the mastoid air cells, absence of the يعني I see absence of the external auditory canal bone parts with يعني ال CT الثاني axial section CT scan show
So absence, just to comment, so
يعني
absence
about
of external
structure
auditory
of
canal, maybe
could
this
be
is just
يعني could
part
be
of the cut.
opacification of the mastoid air cells يعني with the other CT show looks like يعني subdural hematoma يعني could be trauma but I don't see يعني fractures line.
Okay. Okay. That's it.
Okay.
Thank you.
Thanks.
دكتور حسين حمود.
نعم أستاذ، السلام عليكم.
عليكم السلام.
Axial and coronal CT scan of right and left temporal bone.
So two axial cuts for the right and left.
Right and left temporal bone. Showing there is a placement of cochlea with the cystic يعني structure like might be يعني Michel deformity or
Okay, it's a hard case, but I think you get part of the abnormality, which is great. Okay, thank you.
cochlea replaced by cystic.
Okay.
Okay.
Do you want to say something else?
No, I don't.
Okay, let's move to the next.
دكتورة دينا عصام. دكتورة سراء سعدي.
نعم أستاذ.
تفضلي.
axial section CT scan of the temporal bone يعني كأنه أكو abnormality بالسيميسيركولار canal.
So شنو تتوقعين abnormality? Or which semicircular canal has the abnormality?
يعني كأنه posterior.
Okay.
صراحة دكتورة مدى يعني الكوكليا دا أشوفها إنه موجودة 3 turns.
Okay. Again, I mean, we'll go over these cases. Temporal bone disease is always hard, even just the temporal bone anatomy. So, like, it's totally understandable. There is no pressure, especially for the pediatric entities. That's definitely hard. So, you guys are doing a good job. This is the last case, and these are the pathologies that we will go over, and you will see some of these cases, and then by the end, we'll also just set the diagnosis for each cases, just so you keep in your, like, it just stick in your head. So starting with the external auditory canal, we have the dysplasia. So you can see on the picture with abnormality with the shape of the external auditory canal, but can also be external and middle ear. 70% unilateral, 60% of these in male and more on the right side. And as we said, it can be there's a deformity of the pinna of the ear or the auricle. So it's either anotia or microtia, with or without with some external auditory canal stenosis or atresia, and then the tympanic membrane can look either normal or thickened, and the middle ear cavity either small or deformed, and then the same for the ossicles, either absent. Like, it depends on the severity of the abnormality. So either absent, either fused or malformed, dysplastic, whatever. I mean, we just know that when it's external, then the external and the middle ear cavity will be affected, and the abnormality can be variable. So the goal of doing the CT for evaluation of these those patients with external auditory canal atresia is to check for the presence of the stapes, to look for the oval window, see the course of the facial nerve, size and configuration of the middle ear cavity, and then size of the configuration of the mastoid bone, and the status for the ossicular chain. So I think, in my understanding, that mostly we are checking for any quality for constructive surgery. Otherwise, if we will say, like, it's or the possibility even for them to place like the cochlear implant, it just depends on like how much they have from space and how much they have from external and middle ear cavity. So basically assess for these structures and then leave it for the ENT doc to decide. And that's an example of the external auditory canal atresia, so an abnormality of the pinna of the ear, and then we don't see the external auditory canal, but also we don't see the middle ear cavity, like it's more as a severe form. That's the same appearance on the coronal cut, and the external the left side has the normal appearance of external auditory canal. The same patient, and that's the 3D reconstructed images showing the deformity of the external of the pinna of the ear. Okay, middle ear pathologies, starting with the cholesteatoma. So cholesteatoma, we have two types, either the congenital or the acquired cholesteatoma. Congenital cholesteatoma, it's a benign mass related to more as like epithelial cells for related to the embryological origin. But then these epithelial cells can rest within the middle ear cavity behind the tympanic membrane in a patient who doesn't have any prior history of surgery or otitis media or otorrhea. So there's nothing happening within the tympanic membrane. And then location-wise, for the congenital can look different compared to the acquired. So it's usually within the anterior superior aspect of the tympanic cavity near the stapes. So kind of in this location where the stapes is there, or more posterior within the epitympanum, or sometimes they say within the petrous apex and mastoid. On CT, it's a well-defined lesion, again, medial to the ossicles, but when it becomes large lesion, it can erode the adjacent ossicles or even the lateral semicircular canal or the tegment tympani. On MRI, that's basically the same for any cholesteatoma, you can see only peripheral enhancement, but there is no central enhancement, and you can see restricted diffusion on DWI images. So that's the case. It's more as congenital cholesteatoma. It's adjacent to the ossicle. We see it on the axial cuts, but then on the coronal cut, that's where the scutum. The scutum is basically where it's where the tympanic membrane. So it's the separation between the external and middle ear cavity. And when we see the scutum, that's the space is the Prusac space, because this is the malleus, that's the Prusac space, and that's the scutum. However, this one situated more medial to them, to the ossicles. So it's more with congenital cholesteatoma. Acquired cholesteatoma, this is related to abnormality of the tympanic membrane. So there is retraction, there is perforation of the tympanic membrane, and that's what results in kind of entrance of that squamous epithelial cells into the middle ear cavity, resulting in a mass of keratinized ball. There are 3 types of this: the flaccida, the pars flaccida, that's around 80%, or tensa, 15%, and then the sinus tympani. So remember when we talked that there is sinus tympani structure that you need to check, just because it's there's a possibility for cholesteatoma to happen there. That's the sinus tympani cholesteatoma. So it's a small percentage, but still it's important to check. So what are these, the pars flaccida and pars tensa? What are these structures? It's basically related to them, to the attachment to the tympanic membrane. So the pars flaccida, it's more as the upper triangular portion. So it's the smaller portion, but it's more the superior portion. However, pars tensa, it's more like the large portion, the remaining portion of the tympanic membrane. Okay, as we continue with the cholesteatoma, the acquired cholesteatoma. So again, it's a mass lesion with erosion of the ossicles, and then it depends on the location. So pars flaccida, it's the one that happens within the Prusac space between the scutum and the malleus, resulting in erosion of the scutum, and instead of being pointy in appearance, it will become more rounded. And then the tensa, it's more posterior within the mesotympanum, and then we talked about the sinus tympanic, the sinus tympani cholesteatoma. Any cholesteatoma, it can give the restricted diffusion, and there is no enhancement or only peripheral enhancement related to the granulation tissue or the scarring tissue. Example of patient post-op, that was the initial of the CT, and then post-surgical changes. So then they're not sure how much of this component is related to granulation tissue versus being a real cholesteatoma. So then on the MR, you see that there is focus here, that's bright on T2, bright on flare, dark on T1, but some peripheral enhancement. And then on diffusion weighted images, it's restricted diffusion. That's what tells you, okay, only this focus is cholesteatoma. However, all the rest is just post-surgical changes. So that concludes the cholesteatoma. Other entities that can affect the middle ear cavity is a high-riding jugular bulb related to just elevation of the aspect of the superior aspect of the jugular bulb to become to the level of the basal turn of the cochlea. Or but there's no clear middle ear connection. It's more likely to happen on the right side. And that's different from dehiscence of the jugular bulb, which is more likely to be bilateral. But in this one, basically the bone that's covering the area is eroded or resorbed, and then it's bulging into the middle ear cavity. Aberrant internal carotid artery related to a congenital vascular anomaly resulting in failure of formation of the extracranial portion of internal carotid artery with arterial collateral formation. So it will be a tubular structure that coursing through the middle ear cavity. And it's important to recognize that it's an aberrant internal carotid artery rather than being a glomus tympanicum paraganglioma. So that's the appearance. That's the non-contrast CT. You see a tubular structure within the middle ear cavity, but then on the CTA, it's clearly continuing to the internal auditory canal, to the connected to the internal carotid artery. Next is the cholesterol granuloma, which is related to recurrent hemorrhage within the middle ear cavity, causing an inflammatory mass of granulation tissue. It's an expansile mass, bright on T1 and T2, commonly within the middle ear cavity, but can happen within the petrous apex or even the orbit. And that's the case that we had. So it was bright on T2, bright on T1, and then I showed the one with contrast just because in case that you would think, okay, it's a bright on T1, so it could be blood product, could be also fat, but then the post-contrast, it's fat saturated, and it's remaining bright, so that's what also confirm it's more as blood product related to cholesterol granuloma. Next is the automastoiditis. So I would say that there are times that you will see just an effusion within the mastoid ear cells and the middle ear cavity. Not every effusion means it's mastoiditis, and we shouldn't overcall it. Like it's similar to the like the sinuses. When we see sinus disease, it could be just a sinus disease. We use the fluid level to say it's acute etiology. But other than this, But other than this, it doesn't mean every time it's automastoiditis. If you see resorption or demineralization of internal septation within the mastoid ear cells and forming of a big pockets, and that's what they call it, the coalescent mastoiditis, or you see more as external, like periauricular soft tissue swelling, or in the proper clinical context, when the patient is referred really because of fever and ear pain, then you should raise the suspicion. Other than this, you shouldn't always call it that this is consistent with acute mastoiditis, just so we don't overcall these things. And again, when it's extensive with the resorption of the septation, it can result in intramastoid empyema and osteomyelitis. So on CT, again, we see the opacification, we see destruction and loss of septation, destruction of the wall of the sigmoid plate. And on MRI, we can see the enhancement of all these inflammatory debris. And we can see a pockets of abscess formation, the non-enhancing pocket formation. But then the automastoiditis, especially in pediatric with any facial related infection, they have high risk for complication, including the subperiosteal abscess, like a periauricular fluid collection, or there's something called Bizold abscess related to a pus material in and around the sternomastoid muscle, or it could be the extension of infection to the middle cranial fossa, resulting in either epidural or temporal lobe abscess. The same for the posterior fossa, so epidural collection or cerebellar abscess. And then always the important things that you should check is the dural sinus thrombosis. So we see a case here that's looks like an infection within the opacification within the mastoid air cells, and then there is subperiosteal abscess adjacent to the mastoid air cells. And then on another cut, there is thrombosis within the transverse sinus. Another patient, there is what looks like petrous appendicitis, but also intraparenchymal abscess. Another patient, we see the opacification of the mastoid air cells, but we see a formation of pockets here, and then an areas of defect within the bone that make you think, okay, there is a break within the sigmoid plate. So then what's the situation within the intracranial structure there? Is there an empyema? Is there just an epidural collection? Is there a thrombosis? And you see that there is what looks like an empyema there. And then you have the diffusion weighted images will give you how much of this is really pus material. So whatever all the opacification within the mastoid air cells, it all has the restricted diffusion. And the same for that, the intracranial empyema, it's all restricted diffusion. For the same patient, we see the enhancement, and then that's just the peripheral enhancement for the empyema. but then also you see that there is filling defect within the sigmoid going to the internal jugular vein. So there is sinus thrombosis too. Okay, so that's conclude the middle ear pathologies. Any question?
Any question? Mark.
Okay, inner ear pathologies. So we'll start with something called common cavity malformation. We talked about the point that the structures, the development of ear structures occur between the 4th and 5th week of gestation. So it's related to arrest of development of the inner ear structures around that time period, resulting in, they call it common cavity, so related to a common cavity between the cochlea and the vestibule. And then on imaging, we'll see again one cavity connecting the cochlea, vestibule, and horizontal semicircular canal. The rest of them, inner ear structures, can be normal, can be absent, can be malformed. So that's an example here for common cavity malformation. It's basically the cochlea is so atretic and abnormal to the way it's kind of connected with the vestibule, but also not just the vestibule, it's even the semicircular canals are all deformed. So that's part of it's like more severe form of abnormality and malformation of all the inner ear structures. Next is what's called the incomplete partition. And really the incomplete partition, it's related to the cochlear partition. So the cochlea has the 2.5 cochlear turn, the basal turn, and then the middle, and then the apical turn. The middle and the apical turn can give you like a coffee bean appearance, and you should always have the basal turn. So there are types within the incomplete partition. So the type 1, it's the cochlea completely lack partitioning and appear as a cystic structure. Type 2 is that the cochlea has a little bit of turn, and so it's basically like a less appearance compared to the type 1. But there's also with the type 2, there's other abnormality. So still with the type 1, it could be just a mild cochlear abnormality that it looks as cystic appearance, lack the modulus and the interscalar septation. Or there is a more severe type of cochlear incomplete partition type 1, which is called cystic cochleovestibular malformation. So the cochlea and the vestibule formed, but each of these cystic in appearance. That's how it looks. Sometimes it can give the figure of 8 appearance. So that's the case that you saw prior. And instead, it's a hard case just because sometimes it really gets confused between the common cavity malformation versus the cystic cochleovestibular malformation. But I would say the main way that we can differentiate is that in cystic cochleovestibular malformation, there is cochlea, but it's cystic, and there is vestibule, and there is some separation between the two. So in this case, this is the cochlea, this is the vestibule, and the same for the left side. But then there is basal turn here. It's slightly wide, the basal turn, but still there is basal turn, and there is cystic cochlea and vestibule. And then there is the large vestibular aqueduct that they consider it part of cochlear incomplete partition type 2. So what's the vestibular aqueduct? The vestibular aqueduct contains two things. Contain the endolymphatic sac and the endolymphatic duct. The sac is more the posterior structure that sits really next to the mastoid air cells. There is an important pathology that can happen is the endolymphatic sac tumor that's associated with von Hippel-Lindau syndrome, where you see some abnormality in that location with some like mottled appearance or moth appearance of the bone related to endolymphatic sac tumor. And then for here, we're talking about the congenital abnormality of large vestibular aqueduct. So normally the size of the vestibular aqueduct at the site of opening, it should be 1.5 millimeter. When it's more than 2 millimeter, then that's where you consider it abnormal. And when there is large vestibular aqueduct, you should check for the cochlear development, just because it can be associated with some sort of incomplete partition between the middle and the apical turn. And that's what they call it, Mondini deformity. We don't use these, the Michel or the Mondini deformity. We really don't use these terminology anymore. Just like it's more as being descriptive of what you see from the abnormality. So that's an example of case. The right side looks normal. And again, I told you before, I don't use much of these measurement, or like I don't keep it in my head. So for the vestibular aqueduct, you should always compare it with the adjacent semicircular canal. It should be around the same width for the adjacent semicircular canal. If you see it wider, like for this case, for example, the vestibular aqueduct is wider even than the horizontal semicircular canal, and it's wider than the posterior. This is the posterior. So then, yes, it's worth calling it that there is large left vestibular aqueduct, which can affect hearing, can result in balance issue. And also in this case, on the left side, there is some dysplastic appearance of the cochlea. Like there's an issue with the partition. We don't see all the interscalar septation. So, and even the modulus is not very clear. So that's what incomplete partition type 2. And these can be bilateral in about 60%. Next is semicircular canal aplasia or hypoplasia. So it can be either one of these semicircular canal or multiple of these. It depends. With charge syndrome, all the semicircular canal can be hypoplastic, but can be also just one of these with a normal or large vestibule in some of these syndrome, the Alagille or Bohr syndrome. The last and not least, the last entity that we will talk about is labyrinthitis ossificans, which is part of healing response to inner ear infection, inflammation, trauma, or surgery. So what will happen is that the fluid that's running within the inner ear structure, the endolymph, it become replaced by bone. So on imaging, what we are going to see is that there will be high density bone material where we should expect the membranous labyrinth. So basically, because it's going to be filled with bone, then we don't see the inner ear structures. Not because it's not there, it's just because it becomes bone, and then now it's all with the otic bone, so we don't see it. And then on T2, you will see that there is low density within the high density. So basically on T2, we'll see the fluid within the endolymphatic structures as being T2 bright structures. That's how we would see the cochlea, how we would see the semicircular canals. But then we don't see these structures because it become dark on T2 because of the bone. So that's the case that I showed you prior. And yes, there was an abnormality within the semicircular canals, but this abnormality is just because it's absent. Sorry, not absent, because it's become bone, so we don't see it. Like we see a little piece, small piece of the horizontal, but then we don't see the rest of the horizontal. We don't see the posterior. This is the aqueduct. And that's the same for the contralateral side. This is the right, this is the left. And then here on the beginning of this picture, this is the basal turn of the cochlea, and there's a piece of bone running through the basal turn. Maybe it's more obvious here, and the same here. So that's what we are seeing, just because of all the mineralization, basically of mineralization of the membranous labyrinth. Okay, so that's basically review of anatomy and embryology, and then talks about the wide spectrum of pediatric ear disease with a focus on the radiological point that can help us in accurate diagnosis and management planning. These are some of the references, and then these are the cases that we went over. That's the congenital cholesteatoma, and that's the scutum here. It's clear. That's the Broussard space. And this one, it's more toward the middle ear cavity adjacent to the ossicles, more medial to the ossicles. And that's the cholesterol granuloma. That's bright on T1, T2, and not affected by fat saturation. The one with automastoiditis with erosions to the sigmoid plate, and then epidural abscess or empyema. Cystic cochleovestibular malformation, where you see cystic cochlea and vestibule and semicircular canal, but they are separated. That's how you say it's cystic cochleovestibular malformation rather than common cavity. And the last one is the labyrinthitis ossificans related to bone formation within the membranous labyrinth, to the point that we don't see these structures as it's kind of absent, but it's because of the bone formation inside that become iso to the adjacent bone. That's on the right and that's on the left. That's it. Any question?
Thank you very much, Dr. Iman, for this nice lecture. وأكيد تعبناك سنتي نص الليل.
Allah يبارك فيك. I know it's a lot. Don't get frustrated. I sent an article to Dr. Ahmad. Hopefully he can share it with you guys. It's just to make it easy and have like a reference so you can use for future. But it's always temporal bone. It's a hard one. And I mean, you need to review it again and again and again and listen to it several times. That's what really will help. Even for our resident, we'll keep saying, hey, do you want to go over temporal bone? Just so temporal bone anatomy, just so you review the anatomy every time. So thank you so much. And thanks for having me.
Thank you very much. شكرا جزيلا دكتور إيمان، وشكرا للحضور. إن شاء الله نلتقيكم بمحاضرات أخرى، وكل عام وأنتم بخير. إن شاء الله سنة 2024 سنة خير عليكم وعلى الجميع إن شاء الله. ألف شكر دكتور إيمان. مع السلامة. شكرا جزيلا.